I was very grateful and honored to be able to give this lecture, and indeed there were a lot of people in the room, both cardiac surgeons and vascular surgeons. I discussed a very difficult pathology, the so-called chronic dissection, which should actually be named as a post-dissection aneurysm. And since a number of years we've attempted to treat these patients by endovascular means with fenestrated and branched grafts in order to exclude the aneurysm completely. It's not easy pathology because it's more complex than standard thoracoabdominal aneurysms, as there are a number of anatomical features that play an important role and that we have to handle in the planning but also in the execution of the technique. Well, it's still a serious operation, even if it's minimal invasive. You have to deal with the patency of the target vessels, and obviously you want to exclude the aneurysm. So it's no doubt that the results are those of thoracoabdominal endovascular surgery, which means that we see some mortality in about 5% of the patients. And that is most of the time due to ischemia or hemorrhage if we perforate a small wire. We pay a lot of attention to that, of course, to avoid it. But as I said, it's difficult anatomy where we have to navigate with our wires and our stents. But overall, we've been able to demonstrate that the technique works in a number of patients, not in all patients, but in suitable patients it can work, and it can also exclude the false lumen completely, or so to speak, the post-dissection aneurysm completely. And in doing so, you prevent rupture and you probably save the life of the patient.